Okay. Yeah. So there's really no pancreas cancer screening. We don't have any good ways of really screening pancreas cancer in general, but there are programs. NYU does have one, MSK has one, at the very least that I know of, that that are trying to better understand patients that have a high risk of pancreatic cancer. Is there a proper way to screen them? None of that is, it's still an ongoing process, so it's not standardized yet. That's one of the tools that they use. So that's one of the tools that they use to actually screen studied screening in the high-risk population.
So to see the pancreas doctor in NYU lingo for EUS for early detection?
So yes, at NYU, they're looking at, they're studying whether you can screen, whether there's benefit to screening high-risk patients. And EUS is one of the tools that they use.
Is it the gallbladder stone could high risk for the pancreas cancer?
Not quite. No.
Next question from the audience. Or you're going to be one other person first. Julie?
Hello. Hi. I have two questions for Dr. Hidalgo. I apologize if I mispronounced your name. My first question, you talked about the RAS inhibitor drugs, and you did mention, well, we saw that it had the longest disease-free progression, but you mentioned that it comes with high toxicity compared to the other drugs. And so I was just wondering, like, how do you balance the risk and the pros with respect to patient quality of life? That's my first question.
So if I understand the question correctly, the single agents that we are testing these days, they're in general, is this on? Yeah, it is. They're in general well tolerated. So there's not an issue of toxicity in the single agents. They induce responses in a high proportion of patients, but the responses are not very durable. The comment that I made about safety is when you combine those small molecules with very aggressive chemotherapy, and we are not sure whether or not that would be totally feasible. In the lung cancer a scenario that we have more experience, the combination of the RAS 12C inhibitors is different, 12C, with chemotherapy and immunotherapy is not very well tolerated, to the point that many of those large studies are being now closed. The field is kind of thinking how you can incorporate those agents in the first line setting. And I suspect that in pancreatic cancer, we may be facing the same problem. There are strategies that we can use, but we will need to explore them. Was that your question? Thank you.
Howard, and then you'll be next, and then you'll be next.
Perfect segue here, Manny. So with regards to RAS inhibitors, you know, the RAS is going to be really important for wound healing, and chemo is really good at causing wounds. And so I wonder if the order of these treatments, the pulsatility of these treatments is really what's critical there. And I'll ask a more specific question since you're giving me the nod that I probably have something. I haven't heard any data about using the RAS inhibitors to allow patients to qualify for resection. Is there anything going on there with the debulking angle?
No, I haven't seen data in early stages yet. I don't know if those are typically the way this goes is that until a drug is approved, companies are very reluctant to provide, but that's going to happen soon. And I think then there will be much more opportunities to move to earlier stages. I think what you said about the sequencing and maybe an alternating, I think we need to be more creative. And I totally agree that would be the way to go.
And Dr. Gaddy, I just want to say one thing with Dr. Gaddy, I think you're dead on with the epigenetics and the inherited trauma aspects. And that's something that we're looking at in pancreatic cancer. And I appreciate you bringing it up.
Thank you.
Please,
Can I go ahead?
please.
Good morning. My name is Celeste. I have worked at Sloan Kettering as a nurse in the operating room for 13 years. I have seen a lot of surgeries for pancreatic cancer. And I have lost people also to pancreatic cancer. Both they're good friends. But anyway, my question is, I notice all the people who develop pancreatic cancer, they were diabetic. I'm not going to say all diabetic will die. You cannot say that of pancreatic cancer, but all the people I know who have died of pancreatic cancer, they all have diabetes. Is there any way they can do some study to see what happened between diabetes and pancreatic cancer?
So that's a very good question. The pancreas, as we may or may not know, is also what makes our insulin, which is very tight and related to diabetes. That's a very good question. So the pancreas, as we all know, is what makes our insulin, and that's related to diabetes. There is a correlation between diabetes, some subset of diabetes, more specifically when diabetes is diagnosed, and pancreatic cancer. But, and there's a lot of work, there's work that's ongoing that's trying to better tease that apart. But it's not a simple case of having diabetes would cause pancreatic cancer. But one of the key things that we do know or we do see is developing diabetes at an older age should prompt you to make sure that you look for pancreatic cancer. So because having pancreatic cancer, one of the earlier signs could be development of diabetes.
So I'm gonna add just a slight bit of color to that answer, which is helpful. So there's a type of diabetes, ma'am, that pancreas cancer patients get that's different from the general population, which is called type 3C. It's where you don't make enough insulin, not because it was wiped out by an autoimmune disease, which causes type 1, but because your pancreas is small. So the gland is small when the cancer grows. You don't make enough insulin. That's different from type 2, which is related to obesity and things like that. So it's insulin insufficiency, which is unique to pancreas cancer. So that's one flavor of diabetes you see. The other one, the common one, type 2. But, you know, it's an important question. And going back to the first question, actually unexplained diabetes is something where the physicians, the GPs should be thinking, is there a reason why my patient has unexplained diabetes? Because that is something that would raise the possibility that they may have something wrong with the homeostasis in the pancreas. Okay, we had another question.
Can I add a little bit really quick?
Yes, ma'am.
I have a little bit more flavor and color as well. I think one of the things I often talk about when I am speaking to communities is the need, and you alluded to this, is to have a primary care doctor that is trustworthy. Remember, I focus on trustworthy as opposed to you trusting them, because that means they will serve as a liaison to all of the appropriate screening and testing. So for instance, my patients that come to me at 45 with a new colorectal cancer diagnosis, I often want to see, is this their first time screening for colon cancer? Did they have proper screening? Or let's just say 46, 47, because for patients that don't have an oncologist in their family or privilege, as I alluded to, your primary care doctor is really going to guide your outcomes. So I would encourage all of you, number one, if you don't have a primary care doctor, to have one, to regularly see your primary care doctor. And if in fact you feel they're not trustworthy, there are so many primary care doctors. That don't mean you have to fire them, but that just means you have options.
Dr. Gady, thank you for speaking today, and all of the panelists. You just mentioned that your primary care physician guides your outcome in terms of your healthcare or your health. I wanted to know, how do physicians typically learn about available clinical trials to then present that as a care option to their patients. I think in the oncology space, and sorry, I forgot to introduce myself. My name is Andrea Thomas, and I'm a clinical trial project manager. So I work in
Yes.
clinical trials. And typically clinical trial for my patients typically come as a last option. So just wondering, how do the physicians learn about the clinical trials?
Mhm.
I have never been to medical school, but I don't think it is something that is deeply taught in medical school. So yes, again, how do you learn about the clinical trials to then offer?
I love that question. And you're right. We are not taught in medical school, at least, I mean, I'm not like 70 years from medical school. I graduated from medical school in 2016, and you're right. You know, when I heard about clinical trials, it certainly wasn't like in a lecture format. I wasn't tested on it. It's definitely not on any in-service training exam. However, now practicing, it'll be 3 years in August that I've been a GI oncologist. It really, to me, in some ways, is determined by the institution that you're at. So I'm at Yale, where we are constantly pushing out trials. And, you know, I think about one of my colleagues, Dr. Michael Cicchini, who is also in the GI oncology space with me. So one of my partners in crime in many ways. And because I want to focus on your question. So when we think about clinical trials, I always tell patients, the advocate earlier, he said guinea pig, and I kind of cringe because that is oftentimes why patients won't get on trials, because they think that. I know what he meant, but I get a little cringy with it. God bless you. But in fact, everything is from a clinical trial. When I think about the Tylenol, I always say, when you took Tylenol today, it was like the same thing with COVID vaccine. You took Tylenol. Do you know about all of the information that went into Tylenol? No, I'm pretty sure you don't. But that's where I start. So we are taught at Yale, and I think it's probably at most academic institutions, we every week have a clinical trial meeting. And every Thursday, I'm always like, oh my gosh, I'm in meetings from 3 to 6 almost every Thursday. Why? Because we're going over our entire portfolio of clinical trials. And that changes week to week. We have one that may close, we have one that may open, and we are learning, okay, what's the eligibility criteria? And I'm a clinical community outreach engagement liaison for our Center for GI Cancer. So I'm always in the room like, how is this going to touch our patients? Is this open at all sites at Yale? That's exactly what I was hired for. So I try to use that privilege intentionally. But then I'm always listening to say, okay, on Friday, I'm going to see this patient that has newly diagnosed pancreatic ductal adenocarcinoma, and they may qualify for our vaccine trial. I am literally thinking about it from a patient-centered standpoint. And we are all taught that at Yale. And I think in general, as an oncologist that practices in the academic setting, we know that all advances, everyone talked about it today. I didn't really talk about it, but my colleagues certainly talked about it. All of these studies are from clinical trials. You know, I tell my patients, this is the best drug I can give you. I know we have standard of care, but our outcomes are showing actually this trial is better than what I can give you standard of care. When I walk into a room, I talk just like this. I don't change my voice. I don't do any of the code switching. Why? Because I need them to know they can trust me. And the fact that I say to them, if I were in your position, I would be on this trial. Or if my grandmother was in this room, I would offer her this trial. So I use my privilege sitting in those meetings to then be able to give it back to my patients.
Thank you.
You're welcome.
Please, Antonio.
Hello? Okay, good. Great presentations. There's 2 quick questions. First question is, for the KRAS inhibitors, do you think it's going to, when it's all said and done, you think it's going to be best to use a pan-KRAS inhibitor or a specific KRAS inhibitor that hits a certain mutation when it's all said and done? That's the first question. And then the second question, we talked about diversity. We talked about underrepresentation of the oncology workforce. Have any thoughts about how we can increase that in terms of increasing, oncologists, diverse cancer researchers, scientists, et cetera, et cetera? So those 2 questions I have.
I'll take the second.
I can start off with the first. So that's a very interesting question. We literally were talking about that just yesterday. Well, the first one, I'll give it a crack. So literally were talking about that just yesterday too. At this point, the answer is it's not known, it's uncertain. The advantages of the allele-specific ones that target specific alleles is they're supposed to be able to give you more specificity and less side effects. And the potential advantage and this was something that was brought up of the pan-KRAS ones is maybe they can help with resistance. If you have a specific, an allele-specific inhibitor, say that targets G12D, and the tumor develops a resistance, maybe one that targets multiple different KRAS would help with that. And we're potentially seeing increase in KRAS wild type expression as a mode of resistance. So maybe the pan-KRAS can also help with targeting that. But I think a lot of that is still more in terms of theory, and we don't know yet. What Dr. Hidalgo pointed out is we're in the era where multiple drugs come out at once. And so several of these trials are ongoing simultaneously. So they're all just there. I think in a few years or in a couple of years, we'll have a better sense.
And I'll take, oh, you go ahead.
Just one comment that the reality is that even with the pan-RAS, the bulk of the patients are DMV. So they claim that there is efficacy outside these two alleles, but that's very hard to understand yet because the groups are very small.
And to your second question, what I didn't acknowledge on the slides because I didn't have time, but I am a product of American Society Clinical Oncology's pathway programs. We say pipeline, I prefer pathway, but when I was a medical student at Loyola, I remember literally where I was sitting in the lecture hall and I got this email from one of my classmates that I graduated with. And she's like, oh my gosh, Jackie, there's this like oncology program. I know you're interested in oncology. You should apply for it. And it was called the Medical Student Rotation. So back then that was like year 3 of the program, which has continued to be funded. And at that time I was matched at University of Chicago with Dr. Everett Vokes, who, if you are an oncologist, you know Dr. Vokes is a heavy hitter. He has been internal medicine chair at University of Chicago for quite some time. And if you can't tell, I'm all about relations. So I still talk to Dr. Vokes to this day. But my point in sharing that is I then did every other pathway program that ASCO has had. And since then, Dr. Pierce, who I showed on the slides, she developed something called the Oncology Summer Internship, which has now been in place probably for about 4 to 6 years. And the purpose of that and how that works is for students that have finished their first year, maybe even their second year, they are given an opportunity to rotate and see different oncologists. They get to see radiation oncologists, they get to see medical oncologists, surgical oncologists, that many of them look like me. Because again, going back to representation, there is something with that concordance. Dr. Coons and I always talk about like there's lack of concordance. She is very much a white woman and I'm very much a Black woman. But I always tell her, I'm like, I think you're kind of Black because we just get along very, very well. Why? Because while she knows there is a color difference, she uses her privilege to uplift me. So I do the same thing for my mentees. Like if there's an opportunity, I'll invite them, I'll mention their name, I will have them in different spaces. So I think it's all about being very intentional recruitment. There's cluster recruitment. So Yale will often have me sit, I tell them I can't do everything. Like I can't recruit everyone here, but we try to recruit in clusters, meaning if Jackie and, what was your name? Andrea, we get recruited together. It's possible that them coming to Yale together, they'll be able to build their own community together and uplift and recruit. So I think there's so many different ways, but I think it really starts at your home institution and really just being intentional about it.
Please.
Spoke about, so thank you. You spoke about people not being informed or having to do research. But I'm thinking that a lot of people don't know that these research projects are going on. So how do we as a community get involved? Because, for example, my husband had small cell carcinoma. He was at a different institution. Downstate is a research hospital. I work in pediatrics, so I don't know the adult oncology, but Dr. Zan, the pediatric oncologist, recommended me to Dr. Shapiro, who was the head of oncology here. I got my husband to go to her after it was end stage anyway, so he didn't even get into the research project. And I said to her, how does people get into this? Because if I didn't work here and know the oncologist, I wouldn't even know about this program that is being offered at Downstate. One of the things that she said to me, and I was so puzzled about it, they cannot advertise these things because it's a state-run institution. To me, this is ridiculous because a lot of minority patients come here to this hospital and they're not given the information. So it's not that people don't want to be in the research. They don't know about these programs that are being offered. So how do we, as healthcare professional individuals, get this information out to the people who needs it?
So I first want to acknowledge a couple of things. Number one, sorry for the loss of your husband. Number one. Number two, I appreciate how you identified your own privilege. Like I did when I spoke earlier. You said, I work here. That is a privilege compared to those that are not employed by SUNY Downstate. So I always try to say, and I said it earlier when Andrea asked me the question, it's on us as providers. It is not my patient's responsibility to know every little thing. It's already hard enough to be a patient. Having cancer alone is tough. Then you're Black. It's tough being Black. Then you may or may not be poor. You may or may, even if you're not poor. I am very privileged as a Black physician, but it is tough being Black. All of these different things that I have as barriers, and which patients certainly have. That's why when they go to their provider, it is on me to be able to say, these are your options. I'm very big, I use my hands, but I also draw. And I always tell my patients, okay, I need you to use your imagination because I am by no means an artist. But that really means I'm a visual learner. And most of my patients, they appreciate that because I'll write it out. I say, okay, number one, this is how you got diagnosed. And I'll go over the pathology. But then when it's time to get first and second line that I mentioned earlier, I tell them, if I go by guidelines, this is what you should get. But if we kind of move off of guidelines, here are your other options. These are the trials that I can offer to you. This is what's open. This is how the drug works. And this is why I think you should get it. And I often say, if it's only true, because I stand by the truth, if in fact I was sitting there with you, I would be taking this drug. I only offer things that if I was in that seat, that I would be willing to take. So again, my point is, it's not your responsibility as the wife of one that you lost. It is the responsibility of a trained, trusted expert to be able to inform the community that they have trials open.
Okay. Thank you.
You're welcome.
It should be pointed out that this issue about the disparity of information is actually shared by all health systems. It's actually not unique to.
Oh yeah.
This
is not a Downstate
unique to
issue.
SUNY Downstate or Yale or Northwell Health or Memorial Sloan Kettering. Everybody has this problem, this lack of information and the lack of connection of a patient and their diagnosis to the opportunities that exist in that healthcare system. In the last session, I saw this blurb about AI and how AI was going to play this big role. Well, HI is the most important, human intelligence, but if you can use the computer to help the human think, that's great. And actually, Dr. Dan King, who's sitting here in his pullover, the red jacket from Northwell Health, figured out an AI-like method that connects the diagnosis of the patient to the team of doctors and nurses that contact that patient to inform them, just like we're talking about here, to actually provide them that information even before the, quote, healthcare system does its usual thing. And by doing so, he was able to essentially provide options to patients. the hope is that concept will be generalized across. Anyway, sorry to give you that color commentary, but I wanted to. This is becoming a increasingly popular session.
And I do have to get back, so I'm like running late on time. I will acknowledge
Dr.
that.
Gaddy can only take a few more questions. And so I just, again, I need to interject one question that came from some folks a while ago and they're scrolled past. And it's a very general concept, which is this issue around standard of care versus clinical trials. It's kind of apropos to many of the comments here. How can being on a clinical trial ever be better than standard of care? Now, many of us in this room have an answer because, for example, we study pancreas cancer. But I would like our clinicians to address that just succinctly, but hopefully in a way that explains that.
Can a trial be better?
How can a clinical trial be better than standard of care? And again, this is a fundamental question I would say is not uncommon out in the outside world or in the inside world. Please.
Most of the study, they will fall in two large groups. One is for patients that have failed standard of care. So there is no standard of care anymore. And therefore the opportunity is to get into a new drug. And for those that there is standard of care, most of the studies, if not all, compare standard of care versus a standard of care plus something else. So in general, you don't sacrifice a standard of care. So the only thing that can be is equal or better, but very unlikely to be worse